Good evening, everyone. Good morning from the US and good evening in the Philippines. I would like to welcome all our participants, our colleagues, our friends from different parts of the world in this forum and this mask ultrasound Zoom meeting. And I'm so happy that all of you are always loyal to this meeting. And for some of you who cannot make it on time, it's okay because anyway, as Nick starts talking, you will be able to catch up with him, and we'll try to learn this new treatment. Of course, not new for Nick, but maybe for some of us here, it may be some new for you. So anyway, I would like to introduce our speaker tonight. Our speaker is a good friend of mine. I met him way maybe 3 4 years ago, Nick, right?
Yeah, I think was it in Orlando?
Yeah, that was in Orlando, right?
Yeah.
Yeah. So it's a very nice to have met him and learn so many things from him, and I'm so happy that I was able to actually uh, got him in the LinkedIn. And so when I saw his name, I said, okay, this is what I'm looking for. so he is actually a very active physiatrist from Wisconsin, and he's doing a lot of procedures for spasticity. And right now he's a residency program director of the Department of PM&R in the Medical College of Wisconsin in Milwaukee, Wisconsin. So we are so happy, Nick, to have you tonight and this morning, of course, for maybe this afternoon in some countries as well. So I would like to welcome you all. But before we begin, let's just have a short prayer and then we will proceed. Let's pray. Loving Father in heaven, we thank you for this opportunity of being together, learning lessons that will help us as physicians to treat our patients. I would like, Lord, to pray that will be with Nick, especially as he delivers his presentation and as he teaches this very important topic on spasticity and how to do the intrathecal Baclofen injection. Thank you, oh God, for this beautiful day. Thank you for life. Thank you, oh God, for being with us today. In Jesus' name we pray. Amen.
Yeah.
So again, welcome everyone. And we're so happy, Nick, to have you, a very distinguished professor. And of course, our lecturer today, this morning and this afternoon from the Medical College of Wisconsin. So, Nick, it's your turn now.
Thank you, Jim. And thank you everyone for tuning in this evening, this afternoon, this morning. As Dr. DeCastro said, I'm Nick Ketchum. I am a physiatrist in the USA in Milwaukee, Wisconsin, just north of Chicago. And I really appreciate the opportunity and thank you for the invitation, Jim, to talk about a topic that is near and dear to my heart, intrathecal baclofen. And we'll go over a brief overview of just so I can make sure that I'm on the same page with everybody, just an overview of spasticity in general, and then we'll dive into intrathecal baclofen thereafter. And if there are any questions, I'll try to look at the chat as much as I can, or I don't know if I'm okay with people chiming in and saying something anytime they have a question. So with that, I'll get started. So before we talk about spasticity, just briefly about the upper motor neuron syndrome that we're all familiar with. Any lesion in the brain or the spinal cord can lead to the upper motor neuron syndrome. And most people think of the negative signs of a stroke or brain injury or spinal cord resulting in weakness. But that's only one part of the upper motor neuron syndrome. There's also overactivity or the positive signs that we see with spasticity, dystonia, and things of that nature. And the aggregate of positive and negative signs and rheologic changes after an upper motor neuron lesion comprises the upper motor neuron syndrome. Now, as a physiatrist, after any upper motor neuron syndrome, I'm trying to do my best to do what we can to decrease the overactivity, because time and rehabilitation and other things can help with the paralysis, but we want to really maintain range of motion and decrease where we can with spasticity, spastic dystonia, and spastic co-contraction, because the overactivity issues are more amenable to treatment than the paralysis. And once something like contracture sets in, that's obviously very hard to treat non-surgically. So if we can treat where we can, specifically with muscle overactivity, we can help reduce contracture, then in turn reduce disability. So again, what is spasticity? Spasticity by Lance back in 1980 is a velocity-dependent increase in tonic stretch reflex, or increase in muscle tone, and it is in part a hyperexcitability of the stretch reflex. Now, this is the most widely used definition for spasticity, as we know, but more recently, Nat Mayer, said, in a group of the Spasm Consortium in Europe, discussed about the fact that maybe the muscle stretch reflex, the velocity-dependent increase in that stretch reflex, is maybe too limited of a definition to talk about things that are part of what we consider spasticity. And so we look at spasticity as being a convoluted mixture of obligatory and compensatory motor behaviors that are difficult to interpret. And there's also overactivity, not just with velocity, but at rest as well. And so where does spasticity come from? Any upper motor neuron injury, like I stated before, it can be cerebral origin or spinal origin, as we know. So again, why does it happen? I think we're getting closer to figuring out why spasticity happens more so than a basic level like this slide talks about. But because of the lack of central inhibition, we get increased motor neuron excitability in the spinal cord with the reduced inhibitory input from the brain, or the reduced inhibitory input that can't get past a lesion in the spinal cord. We get intrinsic neuron changes and hyperexcitability, and these excitatory interneurons are more sensitive to afferent input from the periphery. And very, very simply, pathophysiology of cerebral origin spasticity. The normal brain is delivering inhibitory signals to the spinal cord, and this modulates the stretch reflex, and tone remains normal, and there is no spasticity. But in the damaged brain, that inhibitory signal is not generated, and that lack of neural inhibition leads to spasticity. Likewise, with spinal origin spasticity, inhibitory neurons can get to the alpha motor neurons, but with a damaged spinal cord, that signal cannot get through the damage, and that lack of neural inhibition leads to spasticity below the level of the lesion. And in the US, at least, this is what I have numbers for. How prevalent is spasticity? The take home from this slide is that oftentimes we see spasticity, depending on the nature of why they have spasticity, anywhere between 25 and even 85% of patients with a certain condition, with cerebral palsy being the highest prevalence. But then the question we have to ask ourselves is, well, how problematic is that spasticity? And usually about a third to half the time, that spasticity is problematic and interferes with the patient's function. And we'll talk about more of that in a little bit. So how do we quantify spasticity? There's a lot of different measures of spasticity. The difficult part, as you all know, is that there's really no great measure that has high inter-rater reliability and a good assessment of muscle in and of itself that can be conveyed between people. And so we have what's out there. The Ashworth scale or the Tardot scale are the two most commonly used scales for assessment. In Wisconsin, we use a combination of the two. And you can use electrophysiologic measures in terms of H reflexes in particular. And we can talk about that a little more if we have time at the end and people have interest. So a review of the Ashworth scale. I put this up here for review, but also if we're trying to describe spasticity, a criticism of the Ashworth scale is the fact that, spasticity is trying to describe overactivity of muscle. And 0, 1, 2, 3 look at an increasing muscle overactivity or muscle tone. But once we get to an Ashworth of 4 and a modified Ashworth of 4, the definition of that is the limb is rigid in flexion or extension. Now, if the limb is rigid in flexion or extension, that might be describing severe muscle overactivity, but it might also be describing contracture, which is obviously not describing muscle. And so that's one criticism that our group has about, and others have about, the Ashworth scale. The Tardieu scale actually describes a little better where in the range of motion of a joint the spasticity becomes apparent, or the muscle overactivity becomes apparent. But the Tardieu scale is not a linear scale, it's more of a quantitative scale, because 0, 1, 2, 3, 4 are all varying descriptions of muscle, but it's not an increasing severity, and it doesn't necessarily describe, you can have non-fatigable clonus, for example, but that might not be associated with a severe increase in tone or severe resistance to passive movement. And so, again, we can talk about this later, but our group is trying to develop a scale that is a combination of the Tardieu and the Ashworth scale to better quantify muscle overactivity. So why do we care about spasticity? Again, spasticity can interfere with things. It can be painful. It can get in the way of ambulation, and it can lead to contractures, dislocation. In kids, we can see spasticity resulting in abnormal limb growth, abnormal bone growth, leading to limb length discrepancies, for example. In severe cases, spasticity can lead to abnormal positioning, which can lead to skin breakdown. It can mask volitional movement and impair respiratory function. And again, any afferent input into the central nervous system in somebody who has spasticity, because there's less inhibition coming from the brain to the spinal cord to the alpha motor neurons, any noxious stimulus or increased input into the afferent limb of the reflex arc can lead to increased output because of that decreased inhibition. So similar to autonomic dysreflexia in cervical spinal cord patients, any noxious stimulus can cause a relative increase in spasticity in those who already have spasticity. And I teach my residents this, that in a non-progressive condition like a spinal cord injury or stroke, a patient with spasticity all of a sudden way above their baseline, it's not typically, if they're 3 and 4 years out from their stroke, a result of their stroke in and of itself. We have to look at the other noxious stimuli that might increase that spasticity and treat that first before we say, oh, this patient needs intrathecal baclofen. And again, as we know, spasticity can be advantageous. It's not all bad. Some people, because they lack volitional movement, spasticity can actually substitute for weakness. And so it can help with truncal control or stability in standing. It can assist with transfers because the muscles are continuing to contract. It can prevent edema, prevent deep vein thrombosis. It allows patients to be aware of their noxious stimuli, especially if they have altered sensation after a spinal cord injury or stroke or brain injury. It can also improve cough strength and improve venous return. So how do we treat it? The biggest thing that I stress is we have all these tools in our belt with neurolytic blocks like alcohol and phenol, oral medications and neurotoxins, and intrathecal baclofen. But no matter what we do for spasticity, unless we're aligned with goals in terms of what is reasonable and achievable by that patient, the family, caregivers, and therapists, we as the physicians might think, hey, we treated this spasticity the best we could, but if the patient's expectation was they were going to have a hand like this and turn that back into a normal hand after 10 years from their stroke, well, our expectations aren't aligned. And because we didn't sit down and discuss appropriate, reasonable, and achievable goals, or SMART goals, the SMART, measurable, attainable, and timely goals, by the patient, the family, the caregivers, it might be perceived as a treatment failure. So with our patients, we come up with different goals, and they come in different categories, but we want to make sure that we're specific for our patients to make sure we're all on the same page and we're all going towards the same goal that can be achieved. And so reducing symptoms or reducing these impairments, improving active function, improving mobility, balance, energy demand, improving their ability to perform their activities of daily living by themselves, and then also thinking about passive function, where if the patient can't perform a task on their own, well, they need somebody to help them do that. And so if they have a caregiver that needs to help with toileting, wheelchair and bed positioning, transfers, there's evidence that suggests that spasticity makes these things difficult, increases caregiver burden, increases caregiver burnout, and leaves the patient, less well cared for. And all of this is done, not through one physician, not through one person, but through an interdisciplinary team. As physiatrists, we're I would say the ultimate, team-based player, looking at, who else can help us out with the task at hand. And obviously at the top of the list are the patient and the family, the rehab physician, but also looking at neurology, neurosurgery, orthopedic surgery, and therapy, all working together to achieve a particular patient's goal. And that's also what makes this fun. Treating spasticity is something that, there's no cookbook for it, and every patient is different. And so it's always a challenge. And so for a comprehensive spasticity management team, which in the US, we have a fellowship for people after residency specifically for spasticity management. And we're one of two in the country that only focus on spasticity. And so this is a passion that's near and dear to my heart in terms of comprehensive spasticity management. And one of the big things that we teach our fellows is we try to teach them maybe not to do all these, because we're not surgeons, we're not doing rhizotomies or tendon transfers or lengthenings, but we want to educate our fellows on all of these. But one of the big advantages of our fellowship program is to teach about intrathecal baclofen. So, and I think, intrathecal baclofen is one of the best ways to really, if somebody has severe spasticity, really finely control their spasticity, because it's hard to cut a baclofen pill into 20 different pieces if they need a very precise dose. But with the intrathecal baclofen, we really can truly dial that in to the most appropriate dose for each patient. So with that, I'll spend the rest of the talk talking about intrathecal baclofen. So pharmacology of baclofen, again, a quick review. This is an analog of GABA binding to the GABA B receptors. It inhibits glutamate and aspartate release by blocking calcium influx. It also inhibits GABA motor neuron activity, reduces muscle spindle sensitivity, and through all of this, it inhibits both mono and polysynaptic reflexes. Presynaptically, it binds to 1A afferents in the sensory arc, and postsynaptically to motor neurons. And so we see, both the reduction of overactivity, but also the decrease in muscle stretch reflex, as Stuart Yablon and folks have recently demonstrated. And it's something, when you take orally, large doses are needed to achieve low CSF concentrations. The peak effect is at about 2 hours. Half-life is anywhere between 2.5 and 4 hours. This is largely excreted through the kidneys, so we have to take care in our renally impaired patients. And a small amount, 5 to 15%, is metabolized in the liver. But it's not without side effects. And so oral baclofen the biggest thing our patients complain about is it makes them sleepy. It can cause constipation, reduced attention. You can see hallucinations. In theory, in a patient who has seizures, it could lower the seizure threshold. Honestly, I'm not certain that I've ever seen it truly be the causative factor for reemergence of seizures, but it's always something that we think about. And there's good evidence in spinal origin spasticity, and I know we use it in cerebral origin spasticity, but because of the potential for cognitive side effects in somebody with potential cognitive issues because of their stroke or brain injury, or in the setting of cerebral MS, it's really something that I use very cautiously in our patients. Um, Also in our ambulators, because it's something that can cause dizziness and reduced attention, there could be an increased risk of fall. Also, shortly after the upper motor neuron injury, be it a brain injury or stroke, there's evidence that baclofen might impair further progress of their neurologic recovery, or blunt that curve, and so that might get in the way of a optimal recovery, especially someone shortly after their event. So intrathecal baclofen, putting the baclofen directly into the spinal fluid. This avoids the typical side effects seen in oral administration at most doses. Um, the baclofen actually binds to these GABA receptors in the dorsal horn of the spinal cord, but it doesn't get metabolized in the CSF, and so it's removed via the lymphatics in bulk flow. And by delivering it straight to the CSF, a very general rule of thumb is we like to tell our patients we can get 100 times the effectiveness getting the medication where it needs to go at 100th of the dose. And so looking here, in somebody who's taking 20 milligrams 3 times a day over time, their plasma concentration gets upwards towards 300 nanograms per milliliter, with only a tiny amount actually getting into the CSF. And so large oral doses leading to, very small cerebral spinal fluid concentrations. Looking at intrathecal administration, being on 200 micrograms a day, we see that the plasma concentration is negligible, and the CSF concentration, actually, you get to a steady state that is around 350 micrograms per day, depending on where you're looking at where the catheter is, the spinal fluid level you're assessing from, and we'll talk about that in a minute as well. But Dr. Albright, who is considered the grandfather or the father of the intrathecal baclofen pump, along with Dr. Penn, they looked at plasma levels in patients who were between 77 and 400 micrograms a day. Their baclofen levels in the plasma was at or below 10 nanograms per milliliter, which is the lower limit of quantitation for the gas chromatography assay they were using. So it really is at the lower end of even detectable at upwards of 400 micrograms per day, which is a reasonable dose for intrathecal baclofen. So how do we get the baclofen to the CSF? Well, it's a surgical placement of the pump. The pump is, we play a lot of ice hockey around Wisconsin in the Midwest, and so we tell patients it's about the size of a hockey puck, and I'll show a photo of it in a little bit. But we have a functional neurosurgeon who does deep brain stimulation, intrathecal pumps, and spinal cord stimulation, and that's all he does. And so we have a great relationship with that surgeon. We actually do patient selection, and we do the management of the patients post-operatively. He is our surgeon, and so we assess a patient, make sure they're appropriate for therapy, send them to Dr. Peter, and he does his thing and sends them back to us. And it's a great relationship to have, because I think, at least in the US, a lot of places, they'll have people who do intrathecal baclofen implantations as kind of their side job, and they don't necessarily take the care it takes to be successful with this. And so there's, in the literature, about a 15 to 20% or higher complication rate with intrathecal baclofen, or intrathecal pumps in general, not just baclofen. But actually, our surgeon just recently published his method of how he has the OR set up and how his procedure is and pre and post-operative care. And he actually has a much lower, I believe it's less than 5% complication rate. And so, following his protocol, essentially, we've been able to really make this a successful treatment without the high reported risk of complication. So the pumps are placed subcutaneously or subfascially into typically the right lower quadrant in the abdomen. The catheter is tunneled around the flank into the intrathecal space, and the catheter enters the spinal canal at typically the L3 to 4 level, and then they thread the catheter up to, if people have lower extremity spasticity, usually the mid or low thoracic spinal level. In somebody with upper limb spasticity, this may be as high as cervical. There's also reports of, and we actually have a few of these patients, placing the catheter in the interventricular space in the lateral ventricle, similar to a VP shunt, but kind of in the reverse. And so delivering the baclofen directly to the ventricles, which is seen more for dystonia rather than spasticity. But in the US, that is an off-label use. And so with the catheter placement, again, similar to intrathecal pain pumps, the catheter is placed in a paramedian approach. You don't want to go directly median in that L3-4 level, or else the flexion extension of the spinous processes can act as a fulcrum and splice the catheter. And so you want to go right next to the median. And using fluoroscopy, the catheter is with a guide wire placed up to the prescribed, previously decided upon spinal level. And because our patients are active and we want to keep them active, our surgeon puts strain relief loops behind the pump, and especially in pediatric patients in the case of them growing, and also in the lumbar spine, so it can accommodate for growth and accommodate for movement, and even some movement of the pump in some cases. So the most commonly used pump in the US is the SynchroMed infusion system by Medtronic. And this has obviously 3 components, and there's a photo of it here. And this is approximately 3 inches, 4 inches, I'm sorry, in diameter, 3 inches in diameter. And we have our programmer, which is a Samsung tablet. And then this is the Bluetooth programming head, which connects through the skin non-invasively to the pump to do external programming. And so the pump is able to infuse the drug at the programmed rate. The catheter delivers the medication directly to the intrathecal space in the spinal cord, and the programmer allows for very precise dosing, like I talked about before. This is easily adjustable, non-invasive, and there are various dosing modes to really accommodate the unique lifestyles, functional abilities, what have you, of our patients, to really give them, customized, very individualized therapy. So in the CSF, again, production rates of the CSF vary between 0.3 and 0.6 milliliters per minute. And the total CSF volume in young adults is about 160 milliliters. And this is cleared through the lymphatics about 4 times per day. So in the CSF, the half-life is a little shorter than it is in the plasma, because the catheter level was typically at the mid-thoracic at about the T6 level, and that was suggested to hopefully get better upper extremity effect. The old thinking was that because people are upright most of the day and because of the flow of the CSF, the concentration of baclofen in the CSF was a lumbar to cervical, a 4-to-1 concentration gradient, largely because of gravity. And so to really get that cervical region, you maybe have to increase the dose. But what we're finding is that CSF flow, it's not, it's not like a straw sitting full of fluid and sitting there, in this big open space. It's largely a potential space. And so what Dr. Salino and Dr. Conrad and Dr. Page from Medtronic have looked at, they've looked at, and this came out last January, I believe, in the neuromodulation meeting. But they actually looked at, um, because of the differences in flow between the cervical and lumbar region, where is the concentration the best? And they're still looking at the data. This was an abstract that they published, but the data has been collected. And so what they did is they took, I believe, 24 patients, and they, with fluoroscopy, put the intrathecal catheter up to the low cervical region, and they did a puncture of the CSF to sample the CSF. And then several days later, they pulled down the catheter to the upper thoracic, did the same thing, and they pulled it down to the mid thoracic and then to the lumbar, I believe, and sampled the CSF at different levels to see where the concentration was truly living, depending on the catheter position. Because there's been debate in terms of, does it matter where the catheter is? Do you need to have the tip of the catheter where the medication is coming out of closer to the cervical spine to get upper extremity effect with the baclofen, or does it matter? And so more to come from Dr. Conrad and colleagues, but they are looking at, more precisely how the baclofen and the CSF interplay, which can be helpful for dosing and helpful for surgical planning in terms of where's the best position for the catheter for these folks who receive intrathecal baclofen therapy. So patient selection. So who's a candidate for this? So first and foremost, patients who have severe spasticity of cerebral or spinal origin. And I'll talk about what severe spasticity means in the setting of intrathecal baclofen in a minute. And in the US, the approved indications are the top here: multiple sclerosis, traumatic brain injury, stroke, cerebral palsy, spinal cord injury. The caveat to this is, for whatever reason, our FDA has approved traumatic brain injury only after 1 year since their injury. Now we use it much sooner than 1 year, but for the labeling, 1 year is the earliest you should do a intrathecal pump implant per the FDA. Other reasons, other indications for intrathecal baclofen therapy or intraventricular baclofen therapy include generalized dystonia, hemidystonias, stiff person syndrome, hereditary spastic paraparesis, and a host of other conditions that we've seen. But by and large, our two highest populations at our center are patients with multiple sclerosis, patients with spinal cord injury. So the patient has to have severe spasticity. We'll define that in a minute. They've had to have at least tried oral baclofen. And typically, either they escalated to a dose that they didn't really see a positive effect from, or at low or any doses, they had intolerable side effects like the somnolence, the cognitive issues, dizziness, constipation. They have to have that goal setting talk. They need reasonable and achievable goals. They need to have reliable follow-up. As I'll talk about in a bit, if these patients can't get back to the clinic for follow-up, that can lead to dire consequences. I mentioned that the programming is non-invasive because you use that Bluetooth programmer, hold it outside of the patient's pump, and it communicates with the pump via telemetry. That being said, the pump typically holds, the two different sizes in the US that are available are 40 milliliters and 20 milliliters. And for most of our patients at most of our doses, that equates to usually between 3 and 6 months of drug supply in the pump. And so the patients, before the drug runs out, the patients need to come back into clinic, and then we refill it by placing one needle through the skin into the pump reservoir, into the center. So we place one needle into the center here, pull back the old medication and replace it with a new fresh supply of either 20 milliliters or 40 milliliters of baclofen. Now, if patients can't come back or they miss their appointment and the pump runs dry, well, that can lead to baclofen withdrawal, which can be, like I stated before, very dire in terms of its potential effects. So patients need to have reasonable follow-up. They need to have sufficient body mass to accommodate the pump. This is actually approved in the U.S. for the use in children with spasticity, but there's no age cutoff necessarily. Their body just has to be big enough to accommodate the pump. And they don't have a pediatric pump that's smaller in diameter. The smaller pump is only smaller in thickness, not diameter. And all patients need to have a positive response to a screening test dose, because we wouldn't want to implant this system in somebody who we weren't sure that baclofen was going to have at least some sort of positive effect on their spasticity. And so what does that screening dose look like? So we bring all of our patients in, and actually because of COVID, it's been over a year since we've been able to do a screening test. So that, Dr. Jim, that's one thing with COVID that is still impacted in our practice, is the fact that we're still not able to do screening test dose for intrathecal baclofen. So that's been a real negative for a list of about 30 patients. And so this is depending on where people are at in their practice. I have colleagues who do this at the bedside for a lumbar puncture. Hey, they do it in a surgery center. We do it in our hospital. We actually have, because I don't do fluoroscopic procedures, we have our radiologists help with the lumbar puncture using fluoroscopy. And then we use a bolus of 50 micrograms of baclofen. And then we assess the patient. We have them lay flat for an hour to avoid a post-lumbar puncture headache. And then we have our therapists and ourselves assess the patient at 1, 2, and 4 hours post the lumbar puncture. And if they have a positive response, then that's a positive screening trial. If they don't respond, then we have to wait 24 hours, at least, usually about a week, bring them back and do a higher dose, a 75 microgram bolus. Again, if they respond, and I'll talk about responding in a minute, they're a candidate. That's a positive response to a test dose. If there's no response, we have to wait again, excuse me, another 24 hours at least, and then we do a third time. If after 3 times, and we've escalated the dose to 100 micrograms of intrathecal baclofen in one bolus, if there's no response, then they're not a candidate. If they do respond at that level, then they are a candidate. So what's a positive response? So our practice is to say, we know this patient has severe spasticity. We know the test dose, the screening dose, is only 1 bolus in time. And so knowing that the pump can have variable dosing and variable patterns of dosing, we just want to see, we know that we've done the screening ahead of time in terms of, does this patient have severe function limiting spasticity? Do they have reasonable goals related to their spasticity, that if their spasticity is better controlled, they would have a positive outcome and achieve some of these goals? Do they have reasonable family support and reasonable follow-up? If all those are yes, we know that if the baclofen test dose does anything, the baclofen pump is flexible enough to help us get to those previously agreed upon goals. And so if there's any change in their spasticity, and we use, again, a combination of the Tardieu scale and the Ashworth scale, then we consider that a positive test dose. So we warn our patients, because a lot of our patients who we screen for intrathecal baclofen they ambulate typically. They don't use wheelchairs. And we tell them that on your affected side, or if they're a paraplegic, if they have bilateral lower extremity spasticity, they might use their spasticity to some degree for function to substitute for their weakness. And so some of our patients, we actually reduce their spasticity so much that we really unmask their true degree of weakness that wasn't apparent before. And so they get apparently weak during the test dose, and that scares people if they're not prepared for it. And so they'll say, oh, it made me weak, I don't want this pump. But if they're prepared for the fact that this is a temporary one-shot approach, that it might unmask too much spasticity, but if it does affect your spasticity, well, then we know with the baclofen pump, we can give you the right dose for that individual to make it an effective treatment. And so we educate our patients very thoroughly before time. And so if there's any change in their spasticity, and their function might improve during that day, it might not improve, but we've already decided on the fact that their spasticity is a problem. They've tried other things. They have reasonable goals related to their spasticity, that if there's any change in their spasticity, then we would consider that a positive test dose. Then it's up to them to talk about, well, is this the right choice for me? The other thing that we use is we use an electrodiagnostic study to assess for the response to spasticity. The H reflex in patients with spasticity is increased most of the time, and so it is very sensitive to baclofen, and so intrathecal baclofen will diminish the H reflex. And so as a electrophysiologic assessment, we'll also do that in addition to our clinical assessment of their spasticity. So what does this look like? Before the test dose, we will assess our patients. This is a patient with a T10 spinal cord injury from a motor vehicle crash. And so as you can see, he's got, what we consider pretty severe spasticity. He was Ashworth at least 3s on exam. And this is before the test dose. And you can see his knee extensors and plantar flexors and adductors are wildly spastic. So very, very stiff, very much resistant to passive movement. So on the right here, this is 1 hour post injection. And so we've dramatically decreased this patient's spasticity to the point where passive range is very, very easily achieved. And for this patient, he actually went on to get a baclofen pump, and he's able to be very, very independent in a manual wheelchair, and his spasticity does not cause the problems with positioning and transfers like it did before. This guy, he owns his own construction and contracting company, and is a really active guy. And so the spasticity really got in the way of his ability to be successful in his job, and to do things with his kids. He's got 3 now college-age kids, and he's been able to be as active as possible with them, in large part because of the intrathecal baclofen pump. So, I mentioned weakness, unmasking weakness, and in patients with hemiparesis, a question I always get asked is, well, is the baclofen going to, not only affect the spasticity and reduce that on the stroke side, for example, is the unaffected side going to become too weak? And there's, in the literature, it does not appear the case. And in practice, we see that patients, this is Daisy, she's my superstar. And so, her right side is effective. She has short step length, and she really relies on that left leg for stability. So this is pre-test injection. And then post-test injection, her left side is not weak, and her step length is a little longer. She's able to bear weight better on that right side. She's not perfect, but much more ease of movement. She's still, excessively plantar flexed on the right side, but that transition is much easier in terms of turning once the baclofen was working. And so she actually went ahead to get the pump, and I just saw her a few weeks ago, and she's doing great. So I mentioned severe spasticity, and so I talked about the criticisms of the Ashworth scale, and how a 4 on the Ashworth scale is not necessarily talking about it could be talking about contracture in addition to spasticity. Well, and severe spasticity doesn't necessarily have to mean, when you're considering intrathecal baclofen therapy, a 4 on the Ashworth or modified Ashworth scale. We consider it to severely impact a patient or caregiver's function. And so we have people who have what you would maybe consider mild or moderate spasticity on exam, but it's really a burdensome issue for their life and function. And so if they don't tolerate oral medications, or it's widespread, or I have patients who they have essentially a spastic monoplegia, and they didn't like the fact that with Botox, it took a while for the injections to kick in. They peaked for about a month, and then the injections wore off. And in the US, we have to wait at least 3 months in between injections. And so out of 3 months, she had 1 month that was good. But then the other 2 months, the intervening 2 months on either side of that peak of the injections, she was miserable. And so even though she had what I would consider maybe moderate spasticity in one limb, she elected to have a baclofen pump. And it really got rid of those ups and downs in her function, because she was getting steady control of her spasticity continuously, rather than having to wait every 3 months for neurotoxin injections. So what are the advantages of intrathecal baclofen therapy? It is reversible. You can shut off the pump. We're not cutting dorsal rami. We're not lengthening tendons. This is something that, even though it is a surgery, it is reversible. The dose adjustments are non-invasive, fewer potential side effects than oral medications, with a few exceptions in terms of emergencies. There's a lot of evidence out there that it's effective in reducing spasticity. And we see it anecdotally that it improves our patients' function, comfort, and care for our patients. There are risks, obviously. It is a surgery, and so we tell our patients that up front. This is a surgical procedure, and so we have had patients who otherwise would be, from a spasticity standpoint, very appropriate for intrathecal baclofen, but they were too high of a surgical risk, and so this wasn't something that we could do. You can get too reduced in your spasticity or hypotonia. At higher doses, you can see somnolence. It's very, very uncommon. Again, nausea and vomiting is uncommon. Headache, we can see a post lumbar puncture headache, post implant headache. Catheter complications may occur. They're rare, but they can occur. The catheter can get kinked, can get dislodged, it can become fractured. They've taken strides to reduce the likelihood of a catheter fracture. Overdose is rare. That the pump does not spin wildly out of control and deliver too much medication. Overdose is, in the vast majority of cases, related to a programmer error, or if you put too high of a concentration of medication in the pump unknowingly. Withdrawal is a potential complication if there were a catheter complication or a pump malfunction, again, which is rare. You can see dizziness as well. So abrupt discontinuation of intrathecal baclofen can result in a withdrawal syndrome. The biggest things we look at are fever, altered mental status, exaggerated rebound spasticity, and pruritus without a rash. In rare cases, this can advance to seizures, rhabdomyolysis, organ failure, and death. And the treatment for this is oral baclofen. We in the US don't have IV baclofen yet, but we educate our patients on this. It's very rare to progress to this severity of baclofen withdrawal. So how is it dosed? Definitely, it's very flexible in the way we can do it. Patients can get a simple continuous, is what it's termed, rate, where they get the same rate all day. We can also program the pump to give a bolus throughout the day. Sometimes patients need less spasticity when they're in bed to help with transfers and their ADLs, but they need to rely on their spasticity when they're up and transferring or walking. And so we give them a bolus early in the morning to make them loose for a time. And then they have a lower dose throughout the rest of the day so they can use their spasticity for function. Sometimes we also periodically space our bolus to mimic oral administration and there's issues with flow rate, and with a high flow rate, you might get more of an effect. And so we've actually seen in low doses, or at lower doses, by giving a flex program, these periodically spaced boluses, better effectiveness at a lower dose. And so it's about not just dose, but how fast the baclofen is being infused. The other thing is, well, what dose to pick? Well, we titrate our patients up, starting at a low dose based on their response to the screening trial. And we adjust that up to, where we, find the best benefit. But there's no cookbook at this point to know, okay, what's the target dose based on their diagnosis or their exam. But in our experience, we do see different etiologies of spasticity have different responses to ITB. In our experience, multiple sclerosis typically needs a lower dose than traumatic and anoxic brain injury. And a small sample of our pump population, we have about 350 patients who have baclofen pumps. A small sample, looking at 25 patients, did show that there was a statistically significant difference, even at that small sample size, between the average doses of different diagnoses, going along with that MS being the lowest dose, stroke, sorry, 1 second, and then brain injury. 1 second, sorry. And so there's actually another group that's looked at this that somewhat mimics, mirrors the same information, and our group is looking at our total population, and so that is in progress, and hopefully we'll have data out soon to solidify this. So where does an intrathecal baclofen fit? It's not a last resort treatment necessarily. It doesn't have to be, you have to at least have been on oral baclofen, but you don't have to exhaust all the oral medications and then do neurotoxin and alcohol injections. And then the last resort is intrathecal baclofen. And also it's not exclusive. You don't have to use intrathecal baclofen and not use other modalities for spasticity control. And so being from Wisconsin, there's a lot of farms, and so there's a lot of silos. So we talk about things, if they're separated off, partitioned off, they're in different silos. And so people oftentimes think, well, if you don't do well with therapy, then we start you on oral meds. If you don't do well with oral meds, then you go to neurotoxin. If you don't do well with neurotoxin, then you get to intrathecal baclofen. Well, it's not siloed. It's what works best, what the combination is best for each patient. Also, it's not a stepwise, this is how you have to progress through your treatment regimens. We have patients who, I think everybody needs therapy, and then what combination of these above is the best treatment for them. And you don't have to fail neurotoxin to be a candidate for intrathecal baclofen. And in our practice, about 80% of patients were on oral spasticity medications other than baclofen prior to intrathecal baclofen. 10% still stay on oral medications because they like the ability to control their symptoms, because they don't have a way to adjust the pump themselves. They like to be able to modulate their spasticity on their own. 60% of our patients received botulinum toxins before the injections and still get them afterwards. And usually it's at a smaller dose in a more focal area. And about 5% of our patients undergo orthopedic procedures after their spasticity is controlled. And actually, we've gotten referrals to say, hey, we need to implant a pump in somebody before they could be eligible for this surgery. And so in comprehensive management that we look at, everybody gets therapy. And then some people get ITB, some people get neurotoxin, some people are on oral meds, some people are on all three. And so it's whatever's best for that particular patient. And some new directions for intrathecal baclofen. Looking at, not only the spasticity benefits, but the, quantifying the fact that not having oral medications cause altered mental status or impaired cognition? How does that benefit somebody's cognition in the setting of multiple sclerosis? Musculoskeletal pain in kids. This group actually showed a positive reduction, a significant reduction in musculoskeletal pain that was actually because of their spasticity. And then kind of a new one. Actually, this was revisited. There's a group out of Florida that looked at in rats intrathecal baclofen with TBI, but they're also looking at it in disorders of consciousness to see, does it help promote sleep-wake cycle? Does it help, decrease overactivity, the hyperexcitability enough that people can emerge from disorders of consciousness? Very, very early stuff. And we also use it for neurostorming in our severe TBI patients. We've had a handful of patients that have received it for neurostorming, in addition for their spastic hypertonia. So kind of a whirlwind, but that's my my little overview of intrathecal baclofen for severe spasticity. So if we have any questions.
Thank you, Nick. That was a
Franklin.
very wonderful lecture. Can you still remember Dr. Domingo here?
Yes, Dr. Domingo, how are you?
Doing great, Dr. Nick. Good to see you, sir.
Great to see you too. Great to see you too.
Good to see you. Good to see you doing well and being healthy.
Hey, you too.
Yeah. If it's okay with Dr. De Castro, I'd like to fire off the first question.
Absolutely.
Go ahead.
All right. First of all, how often do you need to replace the pump? How long can it stay there, and does it need to be replaced at all? By the way, it's been an excellent lecture. I know it's a whirlwind lecture, but it was very concise and very, very nicely presented. Thank you, Dr. Nick.
Oh, thank you so much. That means a lot. Great question. I should have put that in that's maybe one thing missing. The battery life does last about 7 years. And so we tell our patients that within the last year of battery life, they need to be assessed for replacement. And the higher the dose, the faster the rotor spins, the quicker the battery runs out. And so if they're on a very high dose or a lot of boluses, then they might need it at 6 years instead of 7 or so. So, but that's we assess the catheter and we have a 3-day hospital stay for the whole system. It's a 1-day hospital stay for the pump replacement. So it's still a surgery, but it's a much easier surgery for patients.
Thank you, Dr. Nick.
Of course.
What symptoms should our patients watch out for just in case there is a malfunction in the pump? I know you said it's rare, but yep. What do we need to watch out for in case of a malfunction?
So it's rebound spasticity worse than before they had the pump, mental status changes, high blood pressure, fever, tachycardia. A portion of the patients get pruritus without a rash. They feel like they have crawlies under their skin and they don't have a rash. And it looks a lot like serotonin syndrome. And so we have to rule that out first.
So these are symptoms similar to withdrawal. Is that correct?
Yep. So it's baclofen withdrawal. Yep.
Very well answered, sir. Thank you very much. Hope to see you in Nashville soon, sir.
Yeah, absolutely. Definitely.
Okay, Nick, I have my question too. So again, congratulations for a very comprehensive talk this morning. I'm just wondering, can the patient titrate the dose by himself, or does he need to go to the doctor every time he needs to adjust the dose?
So for pain, they do have a patient therapy manager that they do have the ability to give themselves boluses for spasticity that's off-label. But we have had patients who it's basically like a PCA, and so they're able to give themselves boluses throughout the day. Now, if you already have boluses programmed in, that mode doesn't work. So they have to get the simple continuous dose, and then we can program in available boluses for them that they can administer themselves.
I see. So whatever how do you know the optimum dose for that? You need to wait for period of time?
So we look at their response to the test dose. So we very precisely document how their test dose went, and then we can estimate how they're going to respond. But it is an estimation. There's no that's the best predictor we have, and so it is a bit of a trial and error.
Okay. So you can always adjust it depending on the presentation of the effect on the patient after the dose is given, right?
Correct. And so what we do is, if it makes them, we give them 50 micrograms at the test dose. If they had a mild response, we might start with 50 micrograms. If we're adding in boluses, if they get too weak, we'll usually cut it in half and start at 25.
I see. Another question is, do you always need to have the neurosurgeon doing this procedure, or are the physiatrists also allowed to do the insertion themselves?
So it's very variable. We have in the US, we have neurosurgeons, orthopedic surgeons, anesthesiologists, physiatrists.
I see. So whoever is trained to do it, right?
Exactly.
I see. Any side effect of baclofen? We know baclofen is toxic to the liver. Do you have to change to have to monitor that as well?
So we honestly don't, and actually in people with some renal impairment, because there's such a low plasma concentration, people usually do very well with it, despite that.
I see. Okay, Pash, you have a question?
Yeah, thank you, Dr. Nick, for this excellent lecture.
Of course.
We're also very happy over here. And I was just curious, you said earlier that it was more about the body mass, right? If the child, there's no actual age. But I'm curious about the youngest that you've ever, given this to, and the oldest, maybe, that you've, the oldest patient and the youngest patient, basically. Thank you.
Of course. So the oldest has been in their upper 80s. I think they were 86 or 87 when they first got their pump. The youngest, I don't do pediatrics much anymore. I'm trying to think of who the youngest patient that we have. I know that I've seen kids, 5, 6, 7, and I've heard reports of younger. So sorry, I don't have a great answer for that.
No, but it's good because I just want to have a mental picture, who could benefit from this more or less.
Absolutely.
And as they grow, and then as they grow older, as you said, maybe there are some factors to reconsider aside from the 7 years, like the length of the catheter and stuff like that. So they have to come back. So definitely more for the younger ones than those who've already stopped growing, right?
Right, and kind of like with a VP shunt, you put the strain relief, you put some coiling behind the pump, and so that can accommodate the growth.
I see.
Thank you, doctor. Thank you so much.
Of course.
Any question from our friends? Any additional question? Well, Dr. Nick, we really appreciate you for your time, and it was a very good learning experience with you. Now I could say that I have listened to you quite well.
Well, thank you, Dr. Jim. I really appreciate the opportunity. It's great to see you and Dr. Domingo. Great to meet you, Dr. Pash, and everybody else. And I'll put my email in the chat if anybody has any questions. So.
Yeah, because sometimes they're just shy probably to ask questions from you. So
yeah, no, anybody can email me anytime.
Yeah. So thank you very much. Oh, it's here now.
Yeah.
Yeah. So Dr. Nick, thank you so much, and be safe wherever you are.
All right. You all too. Be safe, be healthy. Hopefully see you in Nashville.
Yeah. See you soon.
All right. Take care.
Last words, Joe.
Thank you, Dr. Nick. This is definitely one life-changing procedure we wish we had more of here in the Philippines. Right now, we still don't have it, but hopefully soon Dr. De Castro will bring it in.
Well, come on over. We'll do some training. We'll come over to you guys. It'll be great.
Oh yeah, we're looking forward to that, Nick.
All right, sounds good, Jim. Great to see you, Joe.
Yeah.
All right.
Okay, you take care.
Take care.
Okay.
Bye.
God bless. Thank you.